introduce herself, but there we go. It's all you, Dr. Loya. Thanks for
All
starting us
right.
off tonight.
Thanks, Andrew, and thanks, Jessica. I was really excited about this because I think there's so few things in medicine where you can come to something and get a very holistic view of the whole thing. And so much of the chronic diseases that plague us these days are lifestyle related. And both Andrew and Jessica here are a wealth of knowledge in nutrition and fitness, and um, can really help us, I think, prevent a lot of the problems um, that are coming down the line. So I'm Dr. Lauren Loya. I'm originally trained as a conventional family physician. I went to Northwestern University Medical School and practiced family medicine for 10 years, mostly in academic settings where I was teaching, seeing patients, and also teaching medical school students and residents to become family physicians. And at some point along that 10-year journey, um, I realized that medicine didn't seem to be what I thought it was going to be when I went into it. I thought, I was going to help people and family live their most vital and energetic lives. But what I realized was I was seeing patients come in who were my age now, which I thought were older, but not anymore. And they would have multiple medications, maybe 12 or 13 medicines, three or four or five or six of which was needed for their diabetes, their high blood pressure, their heart disease, their high cholesterol, their depression. And then another four or five medications were treating some of the adverse effects or side effects of the first five medicines that they were on. And I found that I was really good at getting all their numbers where they should be, the blood pressure number, the cholesterol number. But people didn't feel good. They still felt tired. They were gaining weight. They were not sleeping well. They hurt. They were achy and lacked motivation. And I realized, I don't have the tools to help these people. They're already at that point where they have these chronic diseases. And I almost left medicine altogether because I thought this isn't what I went into this for. Rather than leaving medicine altogether, I sought out different avenues where I could use my knowledge and skills and try to find a more holistic or integrative way of treating people. And what I learned along the way, and I just want to tell everyone, I promise I'll get to the GLP-1s, but I just want to put them in the background and the context. So, um, our medical model has to do with sickness. In order to get a diagnosis and get a treatment, you have to have a disease or an illness. We do a very bad job at prevention. We do a very bad job at lifestyle related diseases. And I think that there's a role, and I think more people, especially since COVID, are looking for ways to be healthier and to kind of take control of their health. So if the traditional medical model in the US is based on a diagnosis and treatment model, what we do at the Hormone Center is integrative medicine. So yes, we use tools from that kind of regular conventional medical world, but we also focus a lot on lifestyle, and also potentially non-conventional or herbal treatments, or recommending guidance and referrals to different lifestyle modalities, or a referral to acupuncture. So we're taking into account all of the different modes we have to help people, as well as the whole of the person, realizing that all of the systems are related. One of the other things that happens in our medical system is we separate out, like, okay, this is a heart problem, this is a gallbladder problem, this is a liver problem. But really, what we're dealing with when we talk about hormones and weight and insulin and blood sugar, all of the systems are related. What's going on is going on in every cell in the body, and therefore symptoms can be present in all parts of the body. I like to think um, of health and wellness in terms of the building blocks of health. And you'll notice at the base of this, and again, this is very much how integrative medicine, that term, how it's different from kind of your conventional primary care doctor or specialist. we think about genetics as being what you're born with. That's the DNA that you get from your parents, half from your mom, half from your dad, and you can't change it. Just in the layer above that, we have epigenetics. And epigenetics means around the genes or around the DNA. And what that means is there's things we can do in our lifestyle that influence gene expression. And genes can express in a positive way or a negative way. And of course, we want our genes to express in a positive way so that we don't get diabetes, so we don't get the autoimmune disease, so we don't get cancer. And a lot of the things in our lifestyle and then hormone balance and inflammation can affect how those genes express. And so also near the base of this pyramid, I have the four pillars: sleep, stress management, nutrition, and fitness. And those are the things that, we should all be doing every day to maintain our optimal health. But a lot of those things get left by the wayside. Sleep, especially, we sacrifice that for many reasons. We're under chronic persistent stress almost every day without a big let up from that. And the standard American diet is awful with the amount of sugar and processed foods and um, kind of lack of vegetables and whole foods that Andrew will talk more about. And we don't move much. We're pretty sedentary, and we're learning that there are specific types of exercise and fitness that will help our genetic expression better than others. Where we come in at the hormone center is we're usually seeing people at this place where they have imbalances in their hormones and maybe inflammation. We've learned over the years that inflammation is behind probably 90% of chronic disease. And all of these things below can be out of balance and abnormal before you actually develop diabetes or high blood pressure or heart disease or dementia or Parkinson's disease or any of those, autoimmune or chronic inflammatory diseases. And we have a huge chance, A, to intervene at these lower levels to prevent that disease, and B, to improve the lives of those who already have the diagnosis and hopefully minimize the amount of medications that they have to take. So my kind of view into the body is through hormone balance. And the thing to know about hormones, when I say hormone, everyone thinks estrogen and testosterone, but there are other hormone systems, probably 100 hormones in the body, and they are chemical messengers. And the ones we're going to talk about today are released by the brain from the hypothalamus to the pituitary, secreted there, they go into the bloodstream, and then nearly every cell in the body has receptors or little hooks or keyholes for nearly every hormone. And so hormone imbalances, too much or too little, can affect every cell in the body. So the symptoms are can be very diverse and all throughout the body system, because it's those hormones are sending messages from our brain to regulate every cell in the body. When we look at the hormone systems that we can actually do something about, we have four main systems. The thyroid gland, which kind of sits in the neck and regulates our baseline energy and metabolism. The adrenal glands that regulate our stress response, and they're responsible for the production of cortisol. I'm sure we've all heard of that one. The ovaries, if you're a woman, testes, if you're a man, that make our estrogen, progesterone, testosterone in women, testosterone in men. And then finally, the insulin and glucose system, which the insulin is released from the pancreas in response to sugar and carbohydrates and even protein in our diet. So all of these systems interact. And I just want to take a quick minute to tell you what each of them is, because I'm going to tell you how each can affect weight and how each can affect the blood sugar and insulin dynamics, because the body rising insulin levels in response to blood sugar, as well as all of this other hormone dysfunction, can play a big role in weight gain and the difficulty losing weight. So our thyroid gland is responsible for our baseline energy and metabolism. It's often only checked in medicine by checking something called a thyroid stimulating hormone, or TSH. when there are tests to look at the actual thyroid hormones, T4, T3, and even a hormone that's called reverse T3 that blocks thyroid from getting into cells. You know, there's lots of reasons for low thyroid, and it can, if the thyroid is not functioning right, it can be a big contributor to weight gain and difficulty losing weight. In addition, when thyroid is low, that promotes blood sugar abnormalities and insulin resistance. So if the thyroids are baseload energy and metabolism, the adrenal glands are our stress response. And through, several mechanisms, I do a whole talk on thyroid and a whole talk on adrenals, but just know what we're caring about with the adrenal glands for tonight's purposes is the production of cortisol. And cortisol is produced in response to stress. Our adrenal glands evolved to deal with kind of severe, intermittent, life-threatening stressors, from which we would then go back and spend a couple weeks in our cave recovering. Well, now we don't get a couple weeks in our cave recovering, and our stressors are more kind of chronic and persistent and always there. So we have this kind of constant high levels of cortisol production. And why that's important is A, cortisol puts weight on around our middle. And B, cortisol goes to the liver and says, hey, liver, make blood sugar, release some of these stores of blood sugar, because we have to face our threat. We've got to run from our saber-toothed tiger, or we've got to face starvation. And so it's giving our body fuel to be able to function and save our lives in that situation. Our adrenal glands don't know we just have the regular chronic persistent stressors of everyday life. It thinks we're actually in danger. So, that cortisol and that weight gain, that can affect the glucose and insulin directly. For the women who are on the call, our ovaries, women are quite complicated because our hormones are different in those years of our early menstrual cycles and reproductive years, perimenopause and menopause, characterized by, over that time period, our hormone levels dropping. So our estrogen has over 400 functions in the body. So, there are receptors on nearly every cell. But what I want to focus on today is its impact on body composition. So by the time a woman gets through menopause, which is 1 year with no period, the estrogen and progesterone have dropped by about 80 or 90%. And as women lose estrogen, their fat, where the fat deposits in the body changes. So it moves from like the thighs and the legs and the hips and the buttocks. When estrogen levels are higher, that's where estrogen tends to deposit the fat, to the abdominal area. So we lose fat in those other areas, and the more of that body fat comes around the middle. And that's because as we lose estrogen, we become more resistant to the effects of insulin, and our insulin levels rise, depositing that fat around the abdomen. At the same time, our muscle mass is declining. And I say our because I'm 56, so this is happening to me too. So our muscle mass is declining about 1% to 2% a year after age 50. Muscle burns 13 calories per, say, half pound or so per day, whereas fat burns only 4.5 calories per half pound per day, or per 2 pounds per day. I'm sorry, those are both per 2 pounds per day. So, we're about a third of our metabolic rate as that muscle shifts to more fat. So estrogen is really critical to this process. Progesterone has, reports of mixed effects on insulin and weight gain. But we do know that if a woman has too much estrogen, or even a normal amount of estrogen and not enough progesterone, weight gain can occur. Progesterone provides a good balance to estrogen, and really helps in that kind of building block of sleep, as well as stress management, as it tends to reduce anxiety, irritability, and mood swings. Testosterone is important for women too, especially if you think about the fact that we're losing that muscle mass. Testosterone is one of the hormones that really helps build muscle mass, but it doesn't do it alone. You have to stress that muscle in order for testosterone to help the muscle build. And Jessica will talk more about exercise and fitness and muscle and the importance of building muscle. When we find imbalances in hormones in our women, when we replace them, we like to use what's called bioidentical hormones. And I just want to mention this because it matches what the body makes versus a more synthetic or a hormone that's more like a drug or maybe comes from another source. And so we can have effects of too much or too little. And balance is super important. But again, I don't want to really focus on the replacement of those hormones today, just mention that it is important to balance them. For men, testosterone actually it's not as complicated as women, and there's not like a time where the testes shut down. It's a more gradual process, but testosterone can start to drop in the mid 30s. And just as muscle mass is decreasing by 1 or 2% a year after age 50, starting in those mid to late 30s for men, testosterone can drop 1 to 2%. And just like when women lose their estrogen, when men lose their testosterone, they start to lose muscle mass and have that same, metabolic effect where there's less muscle and more fat. But in addition, as there's more fat tissue, particularly around the middle, there's a certain little pesky enzyme in the fat tissue called aromatase that turns testosterone into estrogen. And all men need some estrogen, but when that happens at a larger scale, because the body composition has changed and estrogen is higher and testosterone is lower, that then puts on more belly fat and it starts this vicious cycle. So testosterone in men is critical to weight management and insulin, just like estrogen is in women. So we talked about, the thyroid, the adrenals, the ovaries, and the testes. And now the main part of this that I want to discuss is insulin and how insulin and blood sugar work in the body. So insulin is a very important hormone released by the pancreas in response to us eating a meal, particularly with sugar, carbohydrates, even protein. And what it does is the insulin goes and it binds to like a little keyhole on the cell, a receptor, and it opens the gate in the cell to let the blood sugar molecules from the blood that we've, gotten from our food or from, cortisol in the liver to get into our cells where it can either be used as energy or stored for later. Well, after a lifetime of, sugary beverages, processed foods, eating out, not eating enough fiber, not eating enough protein, whatever that those dietary parameters of the standard American diet are, our body adapts to that insulin level. So over time, it takes more insulin to keep the blood sugar normal. As our insulin rises, it is a growth factor and it deposits fat around our middle. And that fat is active to turn that testosterone into estrogen, but it also makes inflammatory markers. And then again, it gets and it makes more insulin resistance. So you get into a vicious cycle where the insulin levels continue to rise, 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 and you put on more weight and belly fat. And if you don't address the insulin resistance in some way, whether through nutrition or exercise, supplements, medications, all of the other hormones don't work as well. And all of them, those abnormalities are feeding in. So the low thyroid leads to the insulin resistance. The high cortisol leads to the insulin resistance. The loss of estrogen and testosterone lead to the insulin resistance. So, especially, through the aging process, as, men and women get into their 40s and 50s, all of these whammies are hitting at once. And what we hear from our patients is, I'm eating the same way I always did, but now I'm gaining weight. Or I'm doing the things I used to do to lose weight, like I stopped drinking alcohol and I cut out dessert, but now I don't lose a pound. So, we see that things that their body could tolerate when some of those hormone levels were more youthful levels aren't as well tolerated as we age. In addition, as that metabolic dysfunction with the insulin levels rising increases, because they're in a vicious cycle, again, sometimes those things don't work without addressing the problem holistically. So, improving those insulin dynamics, and this is probably critical to, the health not of all of you individually, but the health of our country. Prediabetes is at epidemic levels. There's probably 80, 90 million people in the United States with prediabetes, many of whom don't even know it. And most of them are overweight or fall into the overweight or obese category. And I say these things carefully because there's like this huge weight related thing where it's like, some people will see it as offensive to talk about obesity or to talk about weight. However, there can be real health consequences, if these metabolic markers like insulin and inflammation, et cetera, or are abnormal. So I think it's really important to address. So we have a 10, 15, maybe even 20-year window where insulin levels are rising and insulin resistance is present before someone becomes pre-diabetic or before their blood sugars start to rise. But in most cases, nobody's checking fasting insulin levels as people are gaining weight. It's not something, that you might get a blood sugar checked or a hemoglobin A1C to see if you're pre-diabetic or diabetic, but no one's checking to see like maybe you're in that 10-year period before. The earlier you catch this process and can achieve some weight loss and changes in nutrition and fitness, the better chance you have of not progressing to prediabetes and diabetes. So to improve those insulin dynamics, of course, you work on the building blocks, the nutrition, the fitness, the stress management, and sleep. And this is hard. Like we don't learn this stuff in medical school. So, we love at the Hormone Center to send our patients to case specific nutrition or to have physical therapy like the other participants in this, because that's their area of expertise. And it takes a lot of the, time off our plate of trying to explain to people what they should be eating. I can give them broad guidelines or how they should be exercising, but these are the experts in the optimal programs for people. We use a lot of supplements that target blood sugar, like berberine, cinnamon, chromium. We use a lot of combinations of things, but there are definitely herbs out there that are going to help, but not if you don't change your diet and start to move. And then there's medications, which we wanted to focus a little bit on today, just to help understand what's the environment of, what's going on with these things. What are these injections, the Ozempics of the world? Just a comment before we get to that, we use a lot of metformin at the Hormone Center. It's an old drug that's been around in Europe for, probably 80 years. It's very safe. And it has great effects on stopping that new blood sugar production at the level of the liver. It also enhances the sugar intake in our muscles in response to exercise without needing extra insulin, so it can help with the insulin resistance. But it also has cardioprotective benefits, possibly cognitive protective benefits, and is currently being studied as an anti-aging drug. So, if your doctor recommends it for insulin resistance or prediabetes, it can definitely be part of a comprehensive plan. And now I wanted to move on to the GLP-1 medications. And GLP stands for glucagon-like peptide 1. That doesn't mean anything to most people. The names that you may be familiar with are semaglutide, which comes now as injections or oral pills, and tirzepatide. The semaglutide is known as the brand names Ozempic, which is indicated for diabetes, and Wegovy, which is indicated for weight loss. And then tirzepatide is Mounjaro for diabetes and Zepbound for weight loss. They're also available at compounding pharmacies, that sterile compounding pharmacies that can make them so that you can do different dosing or combine them with things like B12 and amino acids. And we do use a lot of those, especially in patients who, because we like to start them at very low doses, sometimes lower than the recommended doses. But these drugs act on the GLP-1 receptor. And that receptor, again, helps the body improve its insulin response to meals. And interestingly, when we test our patients, we'll see that in the first few months that they're on it, their insulin level rises. But then after a period of time, it starts to normalize the insulin levels so that they don't have the insulin resistance. And they slow the emptying of the stomach. And this slowing of the emptying of the stomach is where a lot of the side effects come from: nausea, vomiting, loss of appetite, sometimes constipation, feeling full or not being able to eat as much. And so a lot of those are dose dependent. So we're working with patients often, like our goal is to keep them on the other side of nausea. I want people to have an appetite and be able to eat and have enough protein and calories in a day so that their body doesn't go into starvation mode. There are some reported potentially serious side effects of these medications. Pancreatitis is mentioned. Um, Often, though, that's in patients who have diabetes. And for those who are using it for weight loss, it's not clear that it's related. But pancreatitis is characterized by abdominal pain. So it's something that we always tell our patients if they experience it to let us know. There are warnings about thyroid cancer in the use of these drugs. There was a big meta-analysis done that looked at patients who were taking these drugs, and we don't see an increased incidence of thyroid cancer in humans. It was seen in animal studies. And then in patients with diabetes, there's a certain type of vision loss that has been seen as well. And so that has been reported. At the Hormone Center, we're big fans of what we call microdosing. We do this with almost everything we do. Our kind of motto is start low with things and go slowly so that patients don't have a lot of side effects. And we're trying to keep weight loss at no more than a pound a week, but even that sometimes seems a little bit much for me. And like a half a pound a week might be better in order to minimize side effects. We don't want people to be nauseated. We don't want them to be vomiting or throwing up, and we want them to have an appetite. It's not always the case. Some people can't tolerate these at all. And then the most common question we get is, do I have to take these forever? And my answer is always the same. And it's always, it depends. I have found over the years, no matter how people are losing weight, that the rate of weight loss seems to have some impact on how quickly someone might gain weight back. And that may not be true, and Andrew may kind of negate me on that, but if you allow the body to adjust over time versus, I know when I see a patient who loses 30 pounds in the first 2 months, that, it won't take them long to regain that weight when we either start to decrease the dose of the drug or take them off of the drug. The other thing it depends upon is what other lifestyle medicine or changes have been made. If people can revamp their diet and eat a whole foods diet that supports the insulin sensitivity and healthy blood sugar, that can be helpful, as well as that exercise. What the studies show is it doesn't really make you lose weight, but it really helps prevent regaining the weight. So it really helps to kind of make those changes stick. And then, of course, are all the other hormones in balance. And even despite all of that, we still have patients, because of their genetics or because that underlying metabolic dysfunction was triggered, they may always need, maybe a lower dose. Maybe they can spread out their doses of the GLP-1s, but they may always need some small amount of that. We do have patients who have come off it, and some have stayed off for a couple of years. But we also have people who end up going back on it if they start to gain a little bit of weight again. I want to stress the importance of testing. I'm going to show you this next slide, and it's going to be scary, but you don't really have to know it. I just want to point out that, we can test the fasting insulin level. We can test the hemoglobin A1C to see what the blood sugar levels are. We can test the triglycerides and the lipid panel, and all of those give us a picture of if some of that weight management problem has to do with insulin resistance, as well as nutrients and inflammation and all these various hormone levels. Blood and any testing, it's important for you to know that all of these tests are the way labs determine reference ranges is they take 100 or 1,000 normal people, they test them for whatever you're looking at, in this case, thyroid. They take the mean in the middle and two standard deviations, and that's where the upper and lower limit go. You can be here just a tenth of a point above the lower end of the range for your thyroid, and you're going to be called fine. And this is what you're going to look like. So, when we're looking at lab ranges, we're trying to get people and see if we get you to the middle of the range or to the upper part of the range, does that feel better? Um, I just want to, we do saliva testing to look at the cellular levels of a lot of the sex hormones and especially cortisol levels. So that can be important, give us important information, because if those insulin levels are high and inflammation levels are high, even though hormone levels might be normal or optimal in the blood, sometimes they're not getting into the cells and tissues. So, I wanted to give you guys this overview of the GLP-1s. I think that you know, there's a group of people that give them a bad rap, that it's looked at as a crutch, or, why can't you just watch what you're putting in your mouth? And, we have patients who are doing everything right in terms of nutrition and fitness and still struggle, with issues with weight. And these medications have helped not only with that, but sometimes with like inflammation and joint pain and autoimmune issues, cardio protection. We've seen it help fatty liver disease, kidney function. So there's a every day a new benefit is coming out of controlling the insulin and sugar dynamics. So don't discount it. On the other hand, we have another group of people who's like, okay, I don't want to make any changes, just give me that shot, and I'm gonna lose my weight, and that's great. But like that's also going to be very difficult to continue without that shot. And there will become a time where these medications then won't work and people will start to gain weight again. So, some things you can do on your own without the help of the hormone center is leave yourself enough time to sleep, work on your stress reduction techniques, whether that's, prayer, meditation, yoga, deep breathing, Tai Chi, whatever you can do to help your body mitigate the effect of stress on the body so that cortisol isn't released. Um, I'm not going to talk at all about exercise or fitness because that's coming. Avoid toxins like pesticides and herbicides and plastics that might stop the breakdown of hormones in your body. Focus on your nutrition. It's essential. Hippocrates, thousands and thousands of years ago, knew that food was what made us sick and food is what healed us. So, it's essential and non-negotiable to make those changes to your diet. Use supplements where appropriate. And here, where we're talking about supplements and prescription medications, really, my recommendation is that extensive testing is needed to know what supplements are appropriate for you, what medications are appropriate for you, and to know that you're doing them safely and in the correct amounts. So just a reminder of the building blocks of a holistic approach to health. And our information, if you need more, we have a lot of information about all of these systems on our website, as well as other educational things regarding each of the hormone systems. So, I hope this helps give you an overview and kind of gives the risks and benefits and the parameters around which GLP-1s can be helpful for weight loss. So that is the end of my presentation. I'm not sure, Andrew and Jessica, if like we want to do individual questions in between or if we want to wait till the end.
Yeah, my gut is maybe we try and take maybe one, two max right now, to
Okay.
give sort of that while the thoughts are burning, and then we can switch over to Jess, and then we can leave some little time at the end as well.
Okay.
So does anyone have a burning question for Dr. Loya? Thank you for that. I always appreciate your framework to help with understanding. And if anyone's doesn't want to speak up, feel free to type away in the chat. I will be monitoring the chat and can read it for you. We have a guest that asked, would PCOS play any role in this?
Yes, so PCOS is polycystic ovary syndrome, and that's one of the situations in a lot of younger women who are still having periods where we're seeing that the majority of patients with PCOS are overweight, and weight is an issue, although there is a subset of lean patients with PCOS. But part of most of our PCOS patients is insulin resistance. So in many of our patients, that's, addressing, we've had great success in addressing that insulin resistance component of PCOS with both metformin and the GLP-1s.
Perfect. And then we have two more, one of which is really quick and one that I think will be a little bit a good other question. And then we'll pause it here and we'll go to Jess. The quick one is, do you check for MTHR? So do you do the MTHFR gene mutation stuff?
Yes. So MTHFR, I don't have it printed out in front of me, but it's methyl tetrahydro something folate,
Yep. Yep.
and it's a it's a SNP, or a certain gene mutation that can cause defects in the body's ability to activate B vitamins and then detoxify through the use of it. It affects glutathione production. And there's associations with these gene mutations and like 30 different chronic diseases, including obesity and weight and insulin resistance and diabetes. And we do, we can check for MTHFR. For a while, we were doing it on everyone, and then people's insurances weren't covering it, and it was costing $800 or so. So then we were telling people, go get it at 23andMe, and then, 23andMe had the big shakeup. So there are certain insurances and certain diagnoses where we've sometimes been able to get that covered. However, how you know that that mutation in the gene is expressing is through checking the homocysteine. And if the homocysteine is elevated above, say, 9 or so, we assume that there's an MTHFR mutation and that it's expressing, and we treat it with a certain type of activated or methylated B vitamin.
Perfect. Okay, and then the last one for you was, any suggestions if weight loss stalls on GLP-1s? And obviously we could go in on this, and I think two of the ways that we can fix it are coming up, but I'll
Yes.
give you a chance to respond for sure.
Yes, I mean, I would say the first thing I do is I sit with people and, see if there were any changes in their nutrition or what they can do to change up their fitness routine. Because again, the body adapts to stuff. So I always tell people, like, think of a banana. Like if I were to peel a banana in a room that we're sitting in, like you're going to smell it real strong for the first, 5, 10 minutes or so. But an hour later, you might not notice it. And so our body gets used to, if we're eating the same thing all the time, or it gets used to if we're doing the same exercise all the time. So I'm going to let those guys talk about, changing up nutrition and fitness. But I always go back and revisit the hormones and is everything else in balance? Because as people lose weight, sometimes they need more estrogen because now not as much is stored in the fat tissue. And if they don't have enough estrogen, the weight might start to come on in the middle again. So I always like kind of go back to the hormones. I look at stress levels. I look at, are they getting enough sleep? And sometimes I just wait. Sometimes a plateau can last a month and then the weight loss can start again. Um, Sometimes I might switch their GLP-1 and switch them to the other one, or lower the dose for a while, or and then come back to it. So there's a lot of different things that you can do. But also remember that there is a limit to the amount of weight loss that you might see with the GLP-1s. The average amount seen in the very controlled studies with semaglutide was 15%, and with the tirzepatide, 20%. So if you were 300 pounds and you've lost 60 pounds, that might be what you're going to get from that drug. So I just encourage people to think about that too. Like if you were, 200 pounds and you've already lost 70, those last 5 pounds might be very difficult to gain from the GLP-1. So
Thank you. Thank you. Okay, we're going to move forward just with time in mind. So, Jess, if you want to kick us off and talk
Mm.
all things movement, we appreciate you. Requesting, I can allow.
All right. And can you see my slide?
Not yet. Dr. Loya, would you see if you can stop your sharing on your side? There we go. And then we're going to do one can share at a time. Try again, Jess. See if it
All
works.
right. Yeah, there we go. Perfect.
Started sharing. Mhm. There it goes. I can see it on my end, and so we are good to go. Kick us off.
Awesome. All right. Yeah, Dr. Loya, thank you so much for that. It's amazing. So much great knowledge and just putting all the pieces together. It's also a biology major, so I mean, all of the cells, all that stuff, just so powerful and really well done in giving that information. My name is Jessica Homer. I am a doctor of physical therapy and I am the director of operations at Hess Physical Therapy. I've been practicing for 12 years and I've been at Hess PT for 12 years. Over those years, right, I have gained certifications in orthopedics, human movement specialty, certifications in manual therapy, but really something that, us at Hess Physical Therapy pride ourselves in is just understanding how everyone has it's an individualized approach to helping someone achieve their goals and understanding big picture and full body and not so much just a narrow point of view, which is just like Dr. Loya mentioned, even from like the systems approach, right? It's not just the heart, it's not just the um cardiovascular or, thyroid. There's everything works together. And I think that's very powerful because that's even when it comes to movement, right? That's what we do at Hess Physical Therapy. We look at you as from an individual and take all of those things into consideration when designing a program. Um, but yeah, today we're talking about that common or the topic that's becoming more and more common, which is the GLP-1 medication in weight loss, right? Everything is just about that weight loss. But on top of that, my perspective is, or what I'm going to be talking about is how physical therapy and movement play a critical role in that weight loss being sustainable, healthy, and safe. Really going to talk about individual care because no two people are going to respond to weight loss or exercise the same. What works for one person may not work for the other. And it's really about guided care for an individual that is going to make this successful. So if I could have you guys take away anything from my presentation or my ability to communicate to you, it's that three things. One, I want you guys to understand what's happening at the level of the muscle. I want you to understand why movement matters. And I really want to give you guys at least an idea of how to approach exercise in a way that will support your body and not stress it. Because I do believe there's that fear or that unknown or those thoughts of like this intensity or this like extreme needs to happen. So I hope I can, show that differently by the end of my presentation. Um, Okay, so how weight loss affects muscles and joints. So when we lose weight, we typically see a number go down on a scale, which is, exciting, or we see, or we associate that with like the loss of body fat. What I want people to realize that when you lose weight fast, typically it can also impact the loss of muscle mass. So you're not just losing body fat, but you're losing muscle mass. And why does that matter? Well, muscle protects our joints, and right, muscle is going to help us move efficiently. It's going to keep us strong and stable. Even Dr. Loya mentioned, I'm sure even Andrew's going to talk about like muscle helps burn more fat or burn like it burns more calories. So having muscle is so important for our body. And when we lose weight quickly, we may be susceptible to losing that muscle mass. So that if we lose muscle mass, we might experience more joint pain than we did, or we might start to experience some activities being harder than they were, even if it was going up the stairs, or you might be feeling more fatigued than you were before, and that wouldn't make sense, right? But losing that muscle will definitely play an impact on that. It'll also change. Sometimes it can change the way, because it helps support and balance our systems. It can make you maybe walk, or your gait may be uneven, your balance may be off. So, you know, I hope you guys understand that yes, weight loss is probably the goal that we're all seeking when we're taking a medication. But I hope you guys can leave with the mindset of it's not just weight loss. Like I want it to be weight loss and preserve muscle mass, weight loss and preserve muscle mass when you are taking this medication, because preserving the muscle mass or even improving muscle is going to allow for this to be long term and sustainable. And that's, we want to feel good. Right? We're doing it to do not just weight loss, right? But to feel good, move more. And that is important. So, right, being proactive rather than reactive. We don't want to wait till we have the joint pain or we feel weaker or we're more tired to address these things. It's really important that we are understanding that we are susceptible to losing muscle mass while losing weight. And if we don't have a program in place to support that, then some other things are going to fall short, or you're going to start to notice some other things. Um, Okay, so movement supports long-term success with the GLP-1 medication. So another thing I know, people will communicate, well, we have to change the way that, you got to move more, you got to exercise more. And that's really hard for someone to even understand, well, like, where do you begin? Where do you begin? What works? And it's tough to give a generalized, hey, let's do X, Y, and Z, because we truly believe in the individualized plan, which I'm going to talk about. But I think what we have to understand that it doesn't have to be some intense 5 days a week hardcore cardio that is going to help you preserve muscle mass, right? It doesn't have to be that. But what it does have to be is it has to be an exercise plan designed for you that's going to help preserve your muscle mass. It has to be an exercise plan that's designed for you that's going to help improve your energy, build your endurance, and really help maintain your progress long term, because that's what it's all about. Um, so, typically we see weight loss happening without strength and without movement. It's just harder to sustain that weight loss. So that's even where Dr. Loya was saying, exercising in combination of using this medication is going to help you keep the weight loss off, or maybe even, potentially get off of the hormone for a period of time if some of your other daily habits are changing, or even just the exercise in general helping with the changing of like the insulin dependence. So uh, a progressive plan is absolutely necessary. um, that's devised for an actual individual and their specific needs. So when do people seek guidance from a physical therapist? I think there's this misconception of like what PTs do, at least at Hess Physical Therapy, right? We do more than just treat pain and injury, even though, right, even Dr. Loya mentioned, she hit that on the nail on the head. Like we are set up to be diagnosed and then treat, right? There has to be a problem before you can come see us. And that's where a lot of these are the reactive problems, right? So when someone has joint pain, then they come see us. When they start to notice they have muscle weakness or an injury, they come see us. But I'm hoping that we can also highlight that you don't necessarily have to have all of those things before seeing us, right? If it's about designing a program to exercise and maintain health and wellness while you're doing this medication, that's going to be imperative for your results. And we do that too, right? We we evaluate and we analyze you as an individual, and take that into consideration when we are planning an exercise program for you. Um, so, right, yeah. So we see joint pain starts to increase. We're feeling weaker, right? Fatigue that makes it hard to stay consistent with programs. That's why people come see us. So individualized exercise programs, what I mean by this, right? No two people in this room are going to have the same strength, the same range of motion or mobility, the same pain history, the same medical history, or even the same goals. So we have to evaluate you and figure out, where is your movement dysfunctions? Where are you at? What are your long-term goals? And then create a program that's going to have the right dosage, the right intensity, the right frequency to match your goals and your needs so that it's sustainable and that you can preserve the muscle mass that is important for the long-term benefits of the weight loss that you are striving for. Um, because again, it's all about feeling stronger, being more confident, and having control of your body in a way that you can feel confident about it. Um, that's really the bulk of what I want to communicate to you all. I think, like I said, there's this misconception of, exercise, and it can be very scary because you don't know where to start. But if you could, take three things away, and that's, if the goal is weight loss, I want the goal to be weight loss while preserving muscle mass, like keeping those two things in line and knowing that while doing that, you can protect your joints, you can improve your energy levels, and having an individualized plan for you to do that is going to make it meaningful. It's going to make it worth doing. It's not going to make that extra barrier of like, where do I go? What do I do? How do I start? Don't even like this exercise. Wow, this hurts my knee, right? It helps avoid all of those things because it's structured to you as the individual. So yeah, I'm open for, questions now or at the end. I'll also put my email in the chat. So if anyone has any individualized or personal questions they want to ask me, you can always email me too.
Thank you, Jess. Does anybody have any questions? Like I said, we can take two, and then I'm gonna jump on in and do the nutrition side. Perfect. And Jess just put her Jessica at hespt.com in the chat. So anybody that's interested in getting more info or more support, their group is awesome. So I've known her and quite a few of the clinicians over there for a long time.
Appreciate that, Andrew.
Okay, we have a question. As you get older, how and when do you push through pain when exercising?
Oh, never. No, if when your body, so there's that, and that's the thing, like when you experience pain, that is your body telling you you are doing it wrong. The pain is like a response of like something is not right. So, um, there is a better way to move, or there's a better way. Maybe it's squatting that you want to do, and that is not off of the table, but maybe there is a mobility deficit at the level of the ankle or the hip joint, right? That needs to be addressed or even just modified on how you're doing it so that you can achieve the result that you're looking for in that exercise without pain. But I always tell every person if you are experiencing pain while you're doing the exercise, it is probably being done wrong or it's not the right exercise for you. Um, Post soreness is a different feeling, right? And that also is an educational piece. I work with all of my patients because they have to understand, you might feel muscle soreness after. We kind of want that feeling, but never during, never joint pain while you are exercising. And that's a very easy thing to actually fix and help. That's where my specialty and my love and my passion comes into educating.
I love that. Yeah, I think people struggle to differentiate between stiffness and soreness versus pain. And it's like the
Hmm.
first two are probably stretching, warming up, being intentional. The last one is an actual problem. And so keep in mind, everybody, I always say physical therapists are the best educated trainers you could ever have, right? They're way beyond it. They're a doctor of physical therapy. But when you think about going to a personal trainer, like someone like Jess has all of that education plus the movement aspects plus the rehabilitation aspects, it's like it's everything you could want from a movement specialist, and so definitely the right people to support you.
Thank you. Yeah, great question.
Yep. And then the other one was, will we have access to the recording? And the answer is yes, we will. We are recording this, and so we will make sure that that link gets posted up. If you logged in through the Eventbrite, that means that we have the ability to blast that out. So we'll send it out to the Eventbrite, and then we'll make sure that everyone that attended is definitely on that list. So, great question there. Any other final questions before with for Jess? I think we are good to go. Okay, that means I'm up. Uh-oh. Let's see. Okay, everybody. Last but not least, I hope, but here we go. You guys will have to tell me at the end. And so, for those of you that don't know, my name is Andrew Wade. I'm a registered dietitian. I am the CEO of Case Specific Nutrition. We are a dietitian group practice here in the Western Pennsylvania area. We have 8 locations in the region, and about 25 clinicians that work with patients of all kinds to support them in achieving their health and wellness goals. Today, I'm going to dig into the nutrition aspect. In the dietetics world, we call it medical nutrition therapy. So, I'm going to be digging into some of the considerations for GLP-1 when we think about anti obesity medications and how we can use nutrition and considerations for body composition to support you, not just in the short term, but also in the long term. I'm not going to read this to you, but I promise I'm super interesting. I have nothing to disclose. Can you tell I did this for a professional group and modified it? So, some of the things we're going to dig into today, we're going to talk through some mechanisms and clinical effects of GLP-1s. I promise not to step on Dr. Loya's toes because she is the master of that. But basically, how these pertain to nutrition management is where I get paid the big bucks. We're going to dig in and identify some dietary and lifestyle interventions to support body composition change and metabolic health during this pharmacologic weight loss. I always like to say it is a lifestyle medicine journey. The medicine is the thing that we're talking about, but we need to make sure the lifestyle knobs are turning as well. I'm a huge fan of what Jess said about body composition. I always say your goal isn't actually weight loss, it's fat loss, and you need to understand the difference. So, we're going to make sure we dig into that. And then last, we're going to implement some practical nutrition strategies to improve your tolerance of the medication, improve your nutrient adequacy, which is something that really a lot of people struggle with, and then make sure we're trying to lock in those long-term outcomes. My job is not to just get you there, it's to keep you there. And I will do a whole heck of a lot of things in my power to make sure we get that to happen. So, why does all of this matter? So, first off, these GLP-1s are absolutely incredible. They've dramatically changed obesity treatment. I've been a clinician now for 12, going on 13 years, I suppose. And prior to the GLP-1 surge, we had, as Dr. Loya said, metformin, which was always, a massive support in insulin sensitivity, and as a result, had a tendency to be metabolically supportive. And then we had what I like to call the gun to your head meds, the phentermines and adrenaline based ones, where it was just like, hey, we're going to go ahead and press hyper fast forward on your body and act surprised when your adrenal gland poops out. I hate it. I hate it. I'm not a doctor, but I also hate it. So let's just say all that. So when these came out, I was super excited because they do have really good potential validity. But as they do at the Hormone Center, dosage matters and what you combine it with, how you do it matters, as with most things when we're an adult. So some of the things Dr. Loya said that I'll repeat. The average weight loss on a semaglutide in clinical studies was 15%. And then your tirzepatide exceeded the 20%. That's that second gen Mounjaro slash Zepbound. These percentages do not address a couple key issues that are my job as the dietitian. Lean mass preservation. So, percent weight loss means that at 20%, a 200-pound person lost 40 pounds. Great. How much of that was fat and how much of that was inflammation? I hope as much of it as humanly possible. How much of that was muscle mass? How much of that was bone density? I hope the answer is none of it. Hold on one sec. There we go. Nutritional adequacy. So when this person was losing the weight, were they starving themselves and causing all sorts of micronutrient deficiencies and triggering starvation mechanisms in the body that when the med gets the unmute button in the form of a lower dose, an expired dose, or a no dose, the body's going to overcompensate and dial back? That is something we want to troubleshoot. GI tolerance. Did the person start throwing up when they ate chicken breasts? Did they get constipated? Are we dealing with really bad bowel issues? If so, that is not a lifestyle modification that's going to last. And again, what behaviors changed? I love to say this. It was one of our more viral clips on my podcast this year. These medications should be thought of as bumpers on the bowling lane. They will make it easier to bowl. They will make it easier to hit pins. They will make it easier to get good at bowling, but you need to roll the damn ball. That being your lifestyle habits. You need to move, you need to hydrate, you need to sleep, you need to eat. This is a great way to learn self-care, but the only people that keep the weight loss and the fat loss on these meds are those who learn the self-care. You have to learn to become the healthier, happier, lighter you. And that is the human that doesn't just get there, they stay there. These meds will help you get there. They do not help most people stay there. So that is an important piece of this. And that is why, in my quick pitch, why MNT matters, why a dietitian matters, and what we do at Case Specific here in a nutshell. Okay. So let's go through this really quick. I don't want to put everyone to sleep so late on a Wednesday, but the mechanism of action. These meds do a couple different things, and Dr. Loya did this extremely well. So I'll do the dietitian elevator marketer pitch. They suppress your appetite. That's one of the things most people know about. They definitely reduce it. They delay your gastric emptying. That's actually how they work. They slow the stomach. GLP-1 is actually, it exists in our body. When you eat a meal, it is the hormone that cascades to the intestinal tract and says food is here, and it is actually what closes the stomach. The difference, that hormone lives for about 3 minutes in your body versus this medication, which lives for 170 hours. So it is constantly telling your stomach to close, which means you will digest more slowly. You will you'll perceive fullness. It has increased satiety signaling as a result of stomach closing, and also through some dopaminergic pathways, which is to say, it could actually have an effect on sweets and favorite foods and certain preferences. It is currently being researched in the world of binge eating disorder and also for smoking cessation and alcohol treatment, which all of that is too soon to tell, but it is to say some of these mechanisms are pretty fascinating. And that kind of doubles down on that central reward modulation where it kind of neutralizes certain aspects. So you'll find that some people that find, it's, oh, I can't keep these things in the house because I just want to eat the entire box. These medications will take that from a binge and a quote unquote craving to a neutral energy, which is, I mean, oh my gosh, talk about reduced food noise. That can be a massive alleviation. The comment being, if we're going to temporarily mute that, that's great. But now we have a ticking time bomb, which is to say we now have to make sure we're going to teach you to have alternatives. Most people, when they binge eat, I'll give you the 30-second version. They are coping, and we need to find another coping mechanism. Said another way, that coping mechanism is doing something for you. Turning it off usually just aims it elsewhere. Our job is to help you aim it at the right things so that when you turn this thing back on, you're like, actually, I kind of have a better outlet now. So once again, bumpers that can help us get better at bowling, still got to bowl the ball. So these mechanisms, they reduce our energy intake. That can affect our nutritional adequacy. The higher the dose, the more intense, right? So appetite suppression, small doses can take the edge off, can quiet the food noise a little bit, can slow digestion and get you into really nice rhythm, which is why Dr. Loya and her team does such a great job of watching smaller, less is more. The lower the dose, the less reliant you are on the med, which means the more your lifestyle habits are responsible for your progress. And that means the easier it's going to be to come off. The higher the doses, the more intense these things are going to be, the closer we're going to get to a starvation reality. And that is what I'm going to be insanely critical of as your best lifestyle advocate. So let's talk through some of this. So one of the things that we've seen in some of these GLP trials, DEXA analysis, which is basically we'll call it a composition analysis, show fat mass reduction and lean mass reduction. The tirzepatide body comp data had 75% fat loss and 25% lean mass loss. The early data was way, way, way more alarming. It was like under 50-50, like more lean mass than fat mass. This is where you get the it depends button. And so at the end of the day, if you're going to take max doses of these, which starves you, there's not adequate protein coming in, and then you're not really moving very much, so you're not protecting muscle, you're not giving muscle a reason to stick around, your body is going to break down fat stores and muscle stores, along with losing water and inflammation along the way. A case for what Jess does and what her team does is resistance training is one of the easiest ways to say, hey, I'm needed, right? It is the signal that tells your body your muscles matter. It will preserve lean body mass. For many people, it can also build lean body mass. And for most people that are trying to get leaner, look healthier, and be more toned, that is a fat down, muscle up equation, not a fat down, muscle down equation. One ends up being the melted candle approach. The other ends up being fit, lean, and healthy. And so we've got to be very considerate of what your muscle mass is doing. These meds alone, which is what this trial showed, don't cause lean mass loss, which was a headline couple of years ago, that, oh my God, these meds eat away at your muscle mass. No, these meds make it easy to undereat, and undereating eats away at your muscle mass if you're not consuming enough protein and not exercising. So a case for exercise, importance of nutrition and resistance training to preserve. As a side note, normal fat loss, a 5 pound fat loss is 1 pound of water and 4 pounds of fat, just because of the water content in fat. And so 80-20 is what we'd consider like actual pure fat loss. 75-25, the med's not far off from what we call baseline. It's how the med is used. And so we do have an opportunity to use these meds appropriately with the right considerations. So once again, I'll beat this to death. The goal is not weight loss. The goal is fat loss. It is lean mass preservation. Ideally, I'd actually want to see lean mass up for most people, especially if we're talking about aging well. Reductions in fall risk and all sorts of things come with that. We want to see metabolic improvements, and so Dr. Loya did a great job of sharing the four what am I trying to say? Things on the stool. What are those called? You guys get what I'm saying. The four legs, there we go. That's the word. So the four legs on the stool, right? This is an entire metabolic system that inputs and outputs matter. These meds, if used appropriately alongside lifestyle, can actually help improve metabolism long term. That is a muscle up, fat down conversation. And then also the goal is sustainable behavior change. I don't want you to just pretend to be healthier you. I actually want you to become healthy you. I don't want you to crash the plane. I want you to land the plane and enjoy your destination. So successful obesity care should improve body composition and function, not just the scale. And that is absolutely a hill that I will die on. Okay, role of MNT. Nutrition therapy supports GLP-1 treatment through quite a few different things. As a dietitian, I get to help you guys keep your lean mass. Adequate protein is a big part of what we do there. Adequate nutrient intake, making sure you're getting a lot of the micronutrients that, again, a slow digestive tract may miss out on. GI symptom management. If you are dealing with abdominal issues, stomach fullness, reflux, constipation, all of these things are actually symptoms that are fairly manageable with the right lifestyle interventions. We'll dig into some of the mechanisms here in a bit and dig into that further. As a dietitian, we work a ton with the behavior change. I like to say we're the habit specialists. We help you navigate how to do things. And so when we think about living and moving and being the lighter, healthier you, we're working on you meeting that person, getting to know that person, and then practicing becoming that person. That is the role of a dietitian. And that is what leads to long-term weight maintenance. That's how we slowly but surely pass the baton of a lifestyle medicine journey to just a lifestyle maintenance, or a lifestyle with a microdose medication with a less is more mindset. Not everybody's going to be able to come off these permanently, but we'll also find, and that's Dr. Loy, I know you're into this research too, some of the things we're seeing with the anti-inflammatory and autoimmune subsets. I am just kind of eating popcorn waiting to learn about it, because I'm seeing some incredible data that makes a case for why some people might want to consider long-term utilization. So more on that as research presents itself. But in the meantime, our goal and ambition has to be that lifestyle is what leads your long-term health and wellness. So some of the things that I'm going to focus on as we think more like the what of it all is protein intake, your resistance training. Are you moving? Are you pushing your muscles? Are you stimulating them to say, yes, I still matter? Your diet quality, dominantly looking at fiber intake, though I will be more critical of fiber gummies and fiber powders than I will be fruits and vegetables. And so we've got to look at the quality and fiber, not just fiber. Hydration, and hydration isn't just water. Hydration is water and electrolytes, which are the things that let water work around the body. And also symptom management. I don't want you surviving on these. I want you thriving on these. And so we want to make sure that the symptoms aren't ruining your day to day, aren't throwing you off, and aren't setting you up to just, basically limp your way to a lighter number on the scale. That is not a healthy outcome. That's not what we're trying to accomplish. So let's dig into protein a little bit. During weight loss, higher protein does quite a few things for us. It preserves our lean body mass a couple different ways. One of them is protein is basically little bricks that the amino acids that protein's made of, I should say, are little bricks. Those bricks are literally what we're made of. Our skin, our fingernails, our hair, our muscles, all of our organs, we are all made of protein essentially. And so the cool part, when you have a lot of bricks available, that means you can go fix a lot of walls throughout your body. And so adequate protein ensures that we are keeping up with the wear and tear that is a part of our human existence. It is also to say that if your body is low on carbohydrates or low on fats, there is a third option, which is your body can convert protein to sugar. It is its least favorite thing to do. It requires a cycle that actually costs more energy than it makes. And so it is literally a starvation mechanism. Think of it as the backup generator in the shed that you have to like put gas in and like yank when the power goes out. It is really not the thing you want the house running on, but if the house is out long enough, you might have to tap into it. So it is to say if you're eating enough protein and not enough of the other things, your body will convert it to sugar and keep you rolling instead of eating your bicep, right? So instead of eating your muscle mass, it'll eat your protein, amino acids in your bloodstream. But dominantly, I would much rather protein be for the building and the progression, not the prevention of cachexia, which would be what that would be called. It also supports our metabolic rate. Protein has the highest thermic effect of food, which is to say it costs the most to digest. Main reason it makes our stomach work hard and everything downstream. So when you eat protein, your basically digestive expense is a little bit higher, so there's a little bit more of a metabolic output. And protein is also, again, a precursor building block to almost everything in our body. Our neurotransmitters, most of our hormones, all of our tissue, we are a protein-based machine. And so when you have adequate protein, your metabolism can kind of do its thing. And last, it improves satiety. Main reason, it melts in the stomach. And so without these GLP-1s, the best way to tell your stomach to close, high protein meal. Anybody that's ever gone to an all-you-can-eat Fogo de Chao or Texas de Brazil experience and kept the card on green and eaten too much meat, that awful feeling you get, that's your stomach going, whoa, this is way too much protein and way too much fat with it. So it does make you full. It is the key to meals, keeping you full. And frankly, a lot of people don't get enough of it, which is why they walk around hungry all the time. Evidence-based targets, I'm going to say the ones on here, and then I'm going to professionally kind of disagree, which is to say 1.2 to 1.5 grams per kilogram per day is considered adequate for muscle preservation. And so if you were going to do math on this, if we were going to kind of switch this over to pounds for all of you, this would be somewhere around 0.6 grams per pound. That's going to prevent your body from withering away. I'm more of a thriving kind of guy. What I'll say is the 1.6 to 2 grams per kilogram is where I have most people live. 2 is kind of the top end where there really isn't going to be any added benefit beyond satiety. We are still far away from anything that would be kidney concerning at that point. But the 1.6 to 2, I'm going to encourage most people to do more like a zero point 0.8 grams per pound. The only reason I don't love the per pound stuff is because this really should be your ideal body weight, not your actual body weight. Said another way, if you have a human in a bigger body that weighs 400 pounds, we shouldn't be giving them zero point 0.8 of 400, 320 grams of protein, way too much for that human. We should be taking their body fat, seeing, oh, they have 50% body fat. We want them to have 20, then do the math, recognize they need to lose about 150 pounds, and then do the math. And so I would much rather do this math behind the scenes while you scroll on Instagram in my office. But it is to say somewhere in that zero point 0.8 grams per kilo or grams per pound could be a good target for you. I also like to say for most people, women should get above 100 grams per day, and men should get above 150. That is a useful rule of thumb, especially when you're on these meds. I will say the higher the dose, the med, the harder it is to get that, which is why we microdose them in the first place. At these microdoses, no problem. At high doses, you're going to think about a chicken breast and burp. It's not great. And so we've got to find that sweet spot where we're not over medicating you to the detriment of your protein needs. Um, some higher targets. Resistance training can add consideration. So if you're someone that gets after it in the gym, we're going to be talking about that too as an expectation, not just an okay. Older adults, depending on kidney function, we're also going to likely start looking at that 1.6 versus 1.8, 2.0. But all to say, protein is very, very important. And again, 100 grams if you're a female listening, is think of it as your floor. And then let's think about 150 as your floor. And that would be the non-case specific recommendation, but at least gets you in the right direction. Um, Protein distribution. Protein's often skewed towards dinner. It's just kind of culturally how we are. There is a benefit to distributing across meals. This is a little bit of a myth bust because the distribution across the meals isn't necessarily for absorption purposes. It's more for digestion purposes. And so your body has a really good ability to absorb protein at many concentrations. There's interesting studies showing absorption at 100-gram protein meals. Like we really don't have an absorption issue. To be fair, we literally started eating breakfast, lunch, and dinner consistently like 70 years ago. And so if we were going through thousands of years where we could only absorb 30 grams of protein when we ate and we only got to eat once every 3 days when we hunted, I don't know that we would have made it very far as humans. So you can get boluses, but the problem is on these meds, your stomach is already closed and a little bit blunted. And so a big protein bolus is going to take you from satisfied to sick if you're not careful. So ideally, you're spreading this across the day to feel a little bit better. I like to think pile of protein each time you eat. And then from there, we can say what size pile? Well, 25 to 40 grams per meal is a fair aim. If you think about that, if you're eating breakfast, lunch, and dinner, that's going to put you somewhere in that 100-gram range. If you're eating breakfast, lunch, dinner, and having a protein snack or a protein shake on top of that, that's what's going to get you a little higher. And so that's somewhere between 3 and 6 ounces of meat if you're thinking about ounces at a table. And so a typical portion of meat is going to fit fairly well, but then it's the consistency. Are we getting protein at breakfast? A lot of people do not eat protein, high protein breakfast. Are we getting a protein at lunch? A lot of people brush through their lunch and don't. Are we getting a protein at dinner? A lot of people make up for it, but on this med, sometimes that make up for it later, you find yourself like, oof, I can't get this down. So we want to spread it earlier so that we can get it going. Okay, I'm not going to overdo this one because we have the expert in the chat, and I don't want her to call me out. But it is to say that one of the things we do have to remember: resistance training is super important. If you don't know how to do it and you've never done it, talk to the best of the best that do it. Jess knows a couple people and can get you in touch. But these are one of the best things that are going to help us preserve muscle mass, support that metabolic rate, improve your functional health, right? Your ability to actually live in this game of Thrive. And so overall, when we see this, it improves body composition outcomes like crazy. I can attest just from a clinician that's worked with hundreds of people on this. Those that are doing resistance training do it during their GLP-1 treatment. It is incredible to watch the toning that happens, the strength that happens, the capability that happens. Again, their bodies are thriving, and it is very evident. And so in the world of, I like to call it the lifestyle knobs, making sure you're turning that exercise knob. I can't emphasize that enough. A couple other notes with resistance training and nutrition in mind is your bone health. Rapid weight loss affects your bone density, and that is with or without these meds. You know, Dr. Loya mentioned the observation she's had that does absolutely have clinical substantiation and biologic mechanism of action behind it. The faster you lose, the more likely you are to gain it back. The faster you lose, the more likely your metabolism is to actually be like blunted, punished, and offset in a way that increases the likelihood it comes back. The faster it comes off, the less likely it is to stay off, right? A way to think about it is if you're trying to land a plane, you can either crash it, which, yeah, that gets you there faster, but you don't get to enjoy your destination. Or you can land the plane. Takes a little bit longer, but then you get to disembark and you get to actually enjoy your arrived destination. Slowing down is a smart thing. It will preserve your bones, it will preserve your muscle mass. It will allow you to build the habits that you need to keep you there. This is not a race. I'm never impressed by how fast people lose weight. I am impressed by the lifestyle habits they commit to that allow them to become the lighter them, the degree to which they commit to them, and the person they become because of those things. It is a harder thing to do. It is a game of chess, and I know checkers sounds really fun, but you're not playing the right game if you're trying to lose weight really quickly. And this is just one other reason why. Quick shout out to all the ladies out there. You stopped building bone density at like 20 years old. And so if you're in your 40s and perimenopausal and trying to work on your body, tanking your bone density right now is a really good way to have a walker at 60. So like, let's not do that. I'm feeling a little sassy tonight. Don't mind me. Diet quality, it matters. Patients reduce food intake dramatically, hence closing the stomach, feeling less full or for less hungry, all that stuff. That can lower your diet quality for a couple reasons. Fiber digests really slowly. Protein digests really slowly. Solid, like quality fats digest really slowly. So the foods that we think of as healthy, they're also naturally appetite regulating, right? I saw, oh God, I could have killed this TikTok guru influencer person. And they called it a GLP-1 diet. And it was literally just like eating real food. And they're like, it's a GLP-1 diet. It's like, no, it's not. It's normal hunger and fullness. That's what everyone should be doing, but no one's doing it, which is why we're here. And I banged my head through a wall and felt a little better. But it is to say, one of the things we watch with these meds is as you titrate the dosage up, your ability to tolerate protein goes down a little. Your ability to digest fiber goes down a little bit. Your ability to digest whole grains as a result, fruits and vegetables, and then healthy fats, things like avocados, nuts, seeds. All of those things have a little chew to them. They require a little digestion. They sit a little longer in the stomach. These are all good things. But with these meds, sometimes these meds can kind of overcompensate, which is why I say with the meds, less is more, because we should be eating these things. These are the anti-inflammatory foods. These are the foods that contain the micronutrients. These are the foods that actually nourish our body in a meaningful way. And this is the diet that the healthier, happier you is going to have to eat anyway. So we need to be treating this med like bumpers on the bowling lane or like training wheels on a bike while we practice. So make sure we're looking for those protein foods at meals. Make sure we're including produce at meals. Make sure we're including, with grains, whole grains that have some fiber to them. And then we want to be thinking about those healthy fats, those nuts, those seeds, those avocados, fish, some of those types of things, some of our more Mediterranean approaches to eating. This really is the main problem for most people. And med or not, this should be the aim. The med definitely can, if dosed right, can help this just because it can kind of like reduce appetite, reduce cravings, and help you aim at these things and give you a chance to get used to these and start to really enjoy them and then get the benefits from them and then be willing to keep doing it to protect it. But it is not always the first priority as I think it should be. But I am the dietitian after all. Couple notes with fiber and gut health. Fiber is huge. So one of the things that I love to myth bust is when people are like, "Yeah, I don't like eat enough fruits and vegetables, but I take a greens blend." Um, Fruits and vegetables are not meant to be eaten for just their antioxidants. They're mostly eaten for the fiber in them, and that fiber does a couple things. One, it regulates your digestive tract. It regulates your satiety, but it also, in addition to like bowel regularity, all that, it's what feeds your gut microbiome. And so your gut bacteria eat that fiber, and that is where most of your serotonin comes from, which is your wellness neurotransmitter that makes you feel okay in life. The anxiety meds that everyone takes, those are meant to help you preserve serotonin that when you eat a trash diet, you're not getting enough of in the first place. And so eating adequately and properly is actually a better way to boost that. And I can't say it'll warrant the removal of a med, but it is to say I wouldn't be surprised if that was a part of many people's journey. So it's just to say fiber and gut health is not just bowel regularity and satiety. It is also microbiome balance. It is microbiome support. And as a result, it's a lot of communication in the body. Nothing replaces the fiber from fruits and vegetables. Fiber gummies do not replace the fiber from fruits and vegetables. Fiber powders do not replace the fiber from fruits and vegetables. And greens powders definitely do not replace fruits and vegetables. Can you eat adequate fruits and vegetables and add those things? Absolutely. Have no problem with them as additions. Supplements are meant to supplement an already great diet or fill a gap that is an appropriate gap. They're not meant to fill like the Grand Canyon of gaps. And so we've got to think of them and put them in their place. Um, Greens powders and things like that can be a really useful anti-inflammatory nudge up for those that are dealing with inflammation. And so I use them periodically as kind of a surgical oomph, if you will. But that's assuming there's a baseline diet that's supporting anti-inflammatory processes. Fiber recommendations: 25 to 38 grams per day. 25 is the floor for women. 35 is actually the floor for men. To give you a perspective, a cup of fruit has around 2 grams of fiber. A cup of vegetables has around 3. Your whole grains have somewhere between 3 and 6 per serving, which is pretty great. So if you're eating 3 balanced meals that contain adequate produce, you are going to be working your way towards these fiber goals fairly well. Um, Gradual increases are recommended. If you're someone that hasn't been eating fiber and you start pounding 2 salads a day, you are not going to be happy. You will be bloated, you will have loose stools, and you will blame me. So I am saying now we are a great resource to help you work your way towards. We need to meet you where you are. And so if you've been a low fiber eater, I'm not gonna write on your report card with red pen, but I definitely want to help you start working towards. And so we'll start adding some of the solubles first, your fruits, and then we'll start to add some other insolubles, things like oats and some of our other starchier things that are a little easier, bring water, nourish the intestine, reduce inflammation. Then we'll start working up your insolubles, a lot of your veg and a lot of your raw veg. And that'll work our way towards. And over the course of 4, 6, 8 weeks, we can really climb a fiber ladder. And what's cool is people start to feel better and better and better when they do that. Hydration. So, common side effects of GLP-1s include nausea and constipation, and decreased thirst cues. People don't feel as thirsty. Um, in addition, headache is another really common one. One of the things that's worth noting is nausea and constipation is very often a hydration issue, and headaches are very often a hydration issue. These meds have a side effect or a mild diuretic effect. So they actually cause sodium loss as a part of their mechanism of action. And then a lot of times people are working on their health and wellness. So they're exercising more, which means they're sweating. So they're losing more sodium. And so this is a med that even if you're doing nothing, you need more water and you need more electrolytes. And then if you're also living that lifestyle, you need more water and you need more electrolytes. And so a lot of times nausea is a hydration issue. A lot of times constipation, hydration issue. A lot of times headache is a constipation issue, or headache is a hydration issue. I encourage people to wake up and have an electrolyte drink of some kind first thing in the morning to hydrate the intestine. It wakes the stomach up. Our intestines is like a giant water slide. And so when you wake up and you don't feel hungry, it's because there's no water on the water slide. And so it's not ready to accept patrons to go down the slide. Drink some water, aka turn the water on, and all of a sudden food will move through your GI tract infinitely better. So before you hit that steady drip of coffee in the veins in the morning, wake up, water, electrolytes, and then have your breakfast and your coffee and do your thing. That will start to prime your body. And these are some of the habits that we troubleshoot with people because they're not intuitive. They oftentimes are things that need to happen. And again, these meds kind of force it to happen to a certain degree. And so these meds make hydration mandatory. You will be miserable on these meds without proper hydration. Hydration recommendations definitely is something we like to personalize for people on these meds. 80 ounces for women and 110 ounces for men would be my recommendation. If you're active, like notably active, we may be nudging above that. But it is to say that's going to be like baseline fluid needs plus your medication fluid needs is kind of where we'd aim. And we want to make sure we're getting fruits throughout the day to get our potassium up. We'd want to make sure there's an electrolyte beverage somewhere in our day to kind of nudge our sodium to start. We're definitely allowed to have some sodium and should have some sodium in our meals. But these are all things that become highly personalized based on the human sitting in front of me. So if you guys want beyond just the recommendation of make sure you're sipping fluids, make sure you're getting enough electrolytes, programming with one of our dietitians is going to be your best bet. Common GI side effects, again, nausea, constipation, diarrhea, reflux, early satiety. Hydration is one of the biggest things that can improve these things. So can timing of meals. People start to get, like, because they're not hungry, they start to graze or peck all day. that doesn't create a normal digestive experience. And so you don't have the assembly line of your GI tract working properly when you do that. Some people will go all day without eating and then try and eat something at the end of the day. That means one, you're like behind on fluid, behind on food, haven't really turned the conveyor belt on, and then you're just piling a whole bunch of stuff on it. And then we act surprised that it gets jammed. The portioning and spread of your food flow, if you will, is going to be one of the main tools in your toolbox to combat these GI side effects. And so, again, an RD in your team to help you with your food flow, help you with your hydration habits. These are the things that aren't just good for the meds. Spoiler alert, they're also the habits you need to have long term if you want to be this healthier you're aiming at. I already mentioned some of these. Smaller meals, slower eating. That one is, I feel like such a hypocrite whenever I say it, but I'm working on it. Reducing high fat foods during your dose increases, just because fats are the slowest digesting thing in the stomach. Limiting alcohol. Spoiler alert, alcohol is literally poison. That's why it causes us to go all wonky and weird. It is never a good idea, if I'm being perfectly honest. Do I enjoy a glass of wine periodically? Yes. At a bachelor party this weekend, did I have an old fashioned? You bet your butt. But limiting it, so it doesn't mean alcohol free. Not everyone has to have get their 30-day chip, but it is to note less is better. And that is something to keep in mind. And then adequate hydration. I will say it over and over and over. The amount of times people on these meds come to our office and they're miserable, and it's like, literally, it's the hydration every time. Fun little dietitian tip. If you're trying to drink more water, your habit isn't drinking more water. Your habit is carrying more water. So you need to get in the habit of having a water bottle everywhere you go. If you don't have one in your car, guess what? You're not going to drink in your car. If you don't have one next to your computer, guess what? You're not going to drink while you're on your computer. Having a hydration habit is actually having a water vessel carrying habit. So that'll help you drink more water instantly. To those of you that always complain and make up the excuse that it's because you got to pee too much, if you're peeing too much, you don't have enough electrolytes, hit an electrolyte packet. Sodium keeps water in you so that you can use it. And then the other thing is that means you're chugging it, not sipping it. Sipping fluid allows proper kidney filtration, allows proper body use. You won't urinate more than you think. And what's really, really fun is if you sipped like shot glass of water 3 times an hour from wake to sleep, you drink 100 ounces of water a day. So I don't want the excuse you can't drink it. You can, you're just too lazy to figure it out. That's what I'm here for. I'm here to help you. Cool. Micronutrient considerations. The reduced food intake is going to hit some of our big ones. Iron deficiency is huge. It's typically in our higher protein foods and those kind of B12 deficiency, same thing. It's in a lot of our protein containing foods. Calcium and vitamin D inadequacy. These are kind of robust anyway. And so these are just extra considerations. There's a couple others we want to keep an eye on, B vitamins and some other things. But when you're working with a dietitian, that's where we can kind of monitor that status. If you're getting enough fruits, enough vegetables, enough protein, we're already way, way, way farther along than most. But it's to say we want to definitely make sure we're troubleshooting this. A multivitamin can be a really good insurance policy, which is to say, is it going to help? But it's at least minimum blanket coverage, right? Safe auto style. If you're going to do it, get a quality one, an active multivitamin. I love Pure Encapsulations. They have one that's literally called One, ONE. Pure Encapsulations One on Amazon. It is a activated B vitamin scenario with really good doses of everything, all like highest quality absorption of all the things. You're going to pay a little more, but your absorption is going to go from 10% to about 80% on average. So that's a little better than Flintstones. So last piece of it, behavior change, it just matters. I can't say it enough. I get a lot of people that ask me like, oh man, are these meds like, are they taking your job away? It's like, no, not even close. They are making my job more valuable. They're making me more necessary. And frankly, they're a great ally if they're used appropriately. Your meal structure, your food flow, your cooking habits, your food access habits, your food environment, how you interact with the holidays, how you go on vacation, how you do date nights, how you deal with stress, how you deal with the burnout at 3 o'clock in the near where all the food is at your office, right? These are all lifestyle things. And so dietitians aren't necessarily to tell you what to do and slap your hand. We're to navigate your life and figure out how to do it, people. And so these meds are great. They give us some really good constraints. But damn, when you're on these, we have serious work to do. And if we're being honest, we have less than 3 years to do it before these meds go away, because your body will get used to them. They're a ticking time bomb. And so year one, we definitely want to be making sure we're putting these habits to play, because at some point we want to make sure the habits are the main part. I always say it's not called a medicine lifestyle journey. It's called a lifestyle medicine journey. It's not just because it sounds better. It's because lifestyle must lead the way here. Lifestyle is how you eat, how you care for yourself. This medication is an amplification for those things. Some follow-up stuff, recommended monitoring. Rate of weight loss, big one. Faster you go down, more likely it is that you don't stay down. Protein intake. If it's not there, you're not going to be there. Muscle function. If you're losing mobility while you're getting lighter, can we realize how crazy that sounds? You're supposed to improve your mobility while you get lighter. So if we're withering away, that means we're losing muscle mass. That means you're losing mobility. Can you imagine losing 100 pounds and not being able to do anything because you've lost so much muscle? No, no, no. Please no. Your GI tolerance, that is definitely something. If we can't hydrate it and feed it right, we're probably doing it wrong. Hydration status, I have to beat people over the head with SIP strategy, but we will get you there. And that's a habit that's good short-term and long-term. Nutrition follow-up improves long-term outcomes. I like to say, as dietitians, we're your director of wellness. We're that person that once a month you get to meet with to make sure the project that is your health and wellness is going on track. Between evening extracurriculars and all sorts of other things going on, it can be really easy to get off track. There's a lot of things that distract us. And so we are here to help you make sure you're prioritizing the right things, troubleshoot the barriers and obstacles, and keep you accountable so that this long-term journey can do what it's supposed to do. Spoiler alert, it's not just the 6 months, 12 months, 18 months of weight loss. It's the decades after that where you need to live like that person. I'm here to help you be that person long-term, and I'm going to pace how you do this part so that you can keep this part. Couple quick notes as we kind of wind down. Clinicians, we should prioritize fueling, protein and diet quality, resistance training behavior, all that good stuff. And then some key takeaways for you. I definitely want to make sure we emphasize these things are powerful tools. They require nutrition therapy. They require resistance training. They require us to be attentive to your symptoms, and they require attention to behavior change. Medication plus lifestyle is going to create a weight loss, but it's going to create a fat loss, and it's going to create a thriving you, which is what we're actually aiming for. Home Depot style, you can do it. We can help. Case specific, just as a heads up, we are a dietitian group. Obviously, we work with Jess at SPT. We work with Dr. Loya intensely. We do have 8 locations in the area: north, south, east, west, center. We've kind of framed Western PA. We even have Erie and Altoona. If you're calling in from those regions, we do virtual visits. Know that we are insurance eligible, and a lot of what we do is preventive, so it can often be covered at 100%. Easiest way to get a hold of us, go on our website, hit our match, answer 5 questions about you. It'll match you with a dietitian and you can get scheduled. Self-promotion, if you love hearing my voice, Case Specific Podcast is 120 episodes in. I've done a couple on GLP-1s and a bunch of other topics, but every month we're hopping in and myth busting and digging into all things nutrition. And then if you love to scroll and you want some motivation scrolling, add me as Mentoring Dietitian on Instagram. So we're here to help. Don't be a stranger if you need us. And again, we work best collaboratively with groups, which is why Dr. Loya and Jess and I wanted to do this. This is an example of a team that is going to be your round table on a journey like this, right? You want to have insightful advisors that are helping you look at all the angles so that you can make sure you're coming to the best conclusion. Clinicians like us play in the sandbox really freaking well together. Dr. Loya left traditional med to get into lifestyle med because that system does not play in the sandbox very well, as she showed with how labs break and how systems, they're just not built for your thriving. They're built for survival only. And so I have massive respect for clinicians like her that took the jump and are facing that big thing. I did it as a dietitian, but that's small pennies compared to doing that as a physician. So just know that we are all here to help. And when you have a really good team behind you, you're going to have way, way better outcomes. So bunch of references. I'll make sure these slides exist, but this is all sorts of nerdy GLP-1 research that currently exists. It's coming along, and we're getting there with them. So, okay.
Thank
Stop
you,
sharing.
Andrew. Thank you. That was
Absolutely.
fantastic. That was wonderful. I really have to work on my fiber. So
Did I motivate you?
you motivated me to work on my fiber
Oh,
intake.
That makes me happy. I love it. Let's see. I want to take a peek. I want to look at the recording. What do you recommend? Prebiotic and probiotics, bacteria types, daily dose. Cool. That's a really fun one. Prebiotics are a scam. So prebiotics are fiber, and if you were eating enough fiber, you wouldn't need them. Americans don't get enough fiber, so we now put fiber in probiotics. It's literally the main fiber in prebiotics you'll see is inulin. Guess what the highest dose of inulin is? An apple. And so please just eat fruit, first of all, and then take your probiotic with it. Probiotic wise, we do gut testing. So we have a gut test called Vitract. It actually, if whenever I want to realize how stupid I am, I talk to their chief medical officer because this dude sequenced the genome of the 500 species of bacteria in their gut and then found isolated isomers in the genome that allows him to actually like see them quickly with like a Q-tip stool swab. Um, and so with a Q-tip, we can actually see what concentration of all 500 bacteria you have in your gut are. I could tell you a probiotic, which is me throwing a dart at a dartboard, or I could walk up and put it in bullseye. I'd rather do that. Most of you are going to be low in Akkermansia because the American public is low in Akkermansia. Most of you are going to have lacto and bifidobacterium that are suboptimal. So most of you would probably do Garden of Life has a women's and a men's. It's a 50 billion and it has 17 strains. So you have 17 unique species, 50 billion cultures. That one doesn't include Akkermansia, but that is a really good bifido and lactose. So it's Garden of Life men's and Garden of Life women's probiotics. I take one with food every day, and then Akkermansia. There's a couple of them out there. The most common brand's Pendulum. They're pretty expensive. We can get you a discount at Case through our full script setup. But then there's also one on Amazon called Tonic, Toniq. And Tonic is they have a tonic Akkermansia, and 2 capsules of that one a day will do you good too. So that'd be the like general rule of thumb of what I've seen across dozens and dozens and dozens of gut tests. But I'd rather you come in and actually see where your gut is lacking. The reason is because you can actually have bad effects coming off of probiotics. People will actually take a crap ton of lactobacillus, and you can actually get like an acidic pH scenario in your colon, and it can cause inflammation. And so I don't really want to just give you probiotics to give them to you. I want to make sure we're giving you the ones back that you're lacking. And spoiler alert, if you're lacking them, it probably means you aren't eating enough fruits and vegetables because that's what they eat. So just a couple fun things there. Have you seen improvements on GLP-1 drugs for patients with celiac, autoimmune? Um, so on my side of things, celiac, I've not seen any improvements or issues. Celiac is so specifically a response to gluten that gluten-free is still going to be the way to manage that. I will note though that celiac people tend to have a tendency, a proclivity towards additional autoimmune and additional inflammatory issues. And Dr. Loya, this is much more your world than mine, but I have witnessed a surprising improvement in inflammatory markers in people with autoimmune disorders on these meds. I had a client in particular that we did lifestyle things, and this patient had rheumatoid arthritis. CRP inflammatory marker was 16 for 10 years prior to us meeting, just quarterly. They monitored it, and that was kind of like borderline flare. We started doing nutrition, lifestyle stuff, lost 15 pounds. This was all just lifestyle. Got that thing down to a 12 after a year of work. And on a 0.25 dose of semaglutide, 6 weeks in. So before there was any notable weight loss, before there was any metabolic progress that would justify this, CRP under 2 and has been under 2 ever since, hasn't had a flare up in 3 years. And I look at that and I just go, that inflammatory mechanism was so adjusted by these meds. And I've seen things like that throughout. So if you don't mind, I don't know what you're seeing or witnessing, but I'd love your insights too.
Yes, we're seeing similar things. The inflammatory marker we're usually checking is the high sensitivity CRP. And we also I've had several patients who have had, consistently high levels. We've done everything else we know how to do to kind of try to get those down. And we have seen that with even lower doses of the GLP-1s. You don't have to get to a very high dose. I don't know that it's curing autoimmunity, and it's not going to cure celiac, but the danger of autoimmunity is that inflammation and then the damage to the joints and muscles, and we definitely see less pain. So, we have patients with fibromyalgia, with rheumatoid arthritis, with lupus, who, it doesn't necessarily change their lupus markers or their rheumatoid arthritis markers, but we see the CRP come down and we see their pain come down. So
Yeah, I love that. It's just so cool. Over the next few years, everybody, we're going to start seeing some of these. And this is where you'll start to notice these meds will start to get secondary prescriptive ability, things like PCOS, things like certain autoimmune disorders. I have no doubt that's coming. Note that you're hearing this from a dietitian that can't prescribe medications, so take it with a grain of salt. I'm Dunning-Krugering. I'm just smart enough to be dangerous in this combo, but I have witnessed a lot of it and definitely am intrigued to see where that goes. But just to double back on the celiac, yes, we work with celiac at Case all the time. These meds can absolutely be paired with that. The biggest thing is just recognizing like celiac is a non-negotiable gluten-free reality. So there's extra considerations and hoops to jump through. We're here to help you troubleshoot that in your day-to-day busy life. I see a diet quality question, getting protein, protein shakes, protein bars, meats, cottage cheese, Greek yogurt. I am a big fan of all the protein sources. And so when I say diet quality, I appreciate you asking that because, the idea of clean or healthy, these are all vague lines that 20 different people would draw 20 different places in the sand. When we're trying to get adequate protein in, we have two goals: getting the protein in and then feeling full from the protein. And so the comment I'd make is if you're someone that's on these meds struggling with appetite, I want you to use things like protein shakes and Greek yogurt and cottage cheeses because they're going to be a little less filling because they're a little bit easier to digest. So we're getting our amino acids and we're getting you less full, noting that you're already full. If I have someone who's really hungry and their main complaint is that they're hungry and they're overeating, I need them to be chewing on their protein more robustly. I need slower digesting protein. So across the spectrum from protein shake all the way over to steak, steak is going to digest slower. Both of them are giving you the amino acids we want, which is that core like metabolic physiologic need. The question from there is how hungry are you and how full do I need to make you? And I would turn those knobs on that front. The main thing with diet quality is honestly, it's produce consumption. Most people just blow past produce. I don't know how many of us had to look at a my plate and a my pyramid and now an upside down rebellion pyramid, all the crazy things that are trying to tell people to eat their damn vegetables. But like, you really just need to eat your vegetables, and most people don't. So, diet quality is more of a eat 5 cups of fruits and vegetables every day, period, as a minimum floor. That isn't a ceiling, that is a floor. If you do that, all the processed food shrinks. If you do that, all the carb sources and the fat shrink. That is how you balance out your diet. It's how you drive proper digestion. And so diet quality is more about the produce consumption than anything. If I'm going to give you the one knob to turn in that world. And then I've got, is fiber via fruit and veg ground in a smoothie still as beneficial? Similar to the protein scenario, it still has the fiber in it because you blended it. The moment you juice it, you strip the fiber. That's no go. But when you blend it, you still have the fiber. That said, you've already done some of the work. The stomach's job is to melt. And so if you've already blended it, it doesn't need as much melting. So the question then is, do you need the stomach to melt or not? So how hungry are you? If you're somebody that's on these meds and you're really struggling to get enough in, a protein smoothie with fruits and veg blended in it, I am a huge fan because we don't have a hunger problem, right? We have a nutrient problem. So I'm going to use that to get those nutrients in. If you're sitting there and you're saying, man, I've been overeating, I want you chewing on meat and I want you chewing on vegetables and I want you noshing on fruit. The other thing is when you come off these meds, this is one of the easiest ways we can turn that knob. What was once a protein smoothie, you go down on the dose, you get a little appetite back. Now we start to eat some real food. You go down further on the dose, you get some appetite back. Now we start to eat salads. And we will actually, as dietitians, walk you up the med, adjust based on your response, balance while you're on, and then when you titrate down, a lot of times we get to add these things back. So everything you two just mentioned are great tools in your toolbox. Think about how and when you're using them, and then pile up your food for a week on a table in your brain. how much of it is protein and produce? If the answer is 80% of it, I've got nothing to say to you other than good job, Chris Pipe 5 through the camera. If it's less than that, we've got work to do, and that's okay. That's what I'm here for. So smoothies all the way. Yeah, I love it. I love it. Last one on our side here, and I'll just preface anybody that has additional questions for Dr. Loya or Jess. I think we can have them take one more each. So first one to tippy type is the first one to get it, but the last one is a Case is great. Oh, love that. I miss Leah. Joy, good news. I am bringing Leah back. She's going to be in an administrative role, but she is at Case. She's not counseling. She's now a mentoring dietitian with me. And so all the RDs, all 25 of our clinicians are learning from Leah and I. And so she is fantastic. I agree. And I was able to win her back. Wahaha. It was one of my big draft picks this year. Dr. Loya, can you discuss the tipping point of the adrenals after chronically high cortisol to the follow on dysfunction and low cortisol, sodium, etc., and how to repair the adrenals? So sounds like some adrenal fatigue resuscitation in a 2-minute response instead of a 1-hour consult. Ready, set,
Yes.
go.
So the 2-minute response, there are 3 stages of adrenal dysfunction. There's the stage where cortisol is high. And this can last for years. So it's not like, you have high cortisol for a month and then you're going to fall into the my adrenals aren't working stage. The second stage can also last for a long time. It's adaptive, but some of the precursor hormones and other hormones from the adrenal glands that balance the cortisol, like pregnenolone, which is the master hormone, and DHEA, which is kind of the counter to the stress hormone. It's more anabolic and helps with stamina and endurance. You come to a phase where now the cortisol, when we measure it, isn't high anymore, but maybe it looks kind of normal, but we see lower other adrenal hormones like the pregnenolone and DHEA. And that's kind of like stage 2 of the adrenal dysfunction. And then stage 3 is when kind of, when we check the 4 cortisols throughout the day, morning, noon, evening, and night, all of those levels are either at the lowest part of the range or fairly flat along the bottom of a curve. And you have low DHEA and pregnenolone. And the first thing I always say is the stressors have to change. A lot of people that end up in this last stage of adrenal dysfunction, this is not Addison's disease or adrenal failure that requires necessarily hydrocortisone or steroids, but lifestyle, picking the stressors that you can eliminate, not being the president of the PTA, not, being the person who says yes to everything. So structuring your life, mitigating the effects of stress. And we love to use adaptogens, various herbal products like rhodiola, eleuthero, ginseng, cordyceps. There's a whole list of adaptogens that will help to support adrenal function. And as a kind of last resort, we'll actually use adrenal glandulars. That being said, sleep is also important. Sleep is when your adrenals heal. A lot of my patients with adrenal dysfunction are, they get energy as they go into the night and they're staying up till 1, 2, 3 o'clock. You must get to bed before 10 because that's when the best healing for the adrenals is going to be. And then dietary wise, you have to get off sugar because sugar is sending, that's also contributing to that cortisol dysfunction. So it's the whole thing, right? It's doing all of these things that as well as supporting individual hormones like pregnenolone, DHEA, possibly testosterone, possibly estrogen. So it's not a simple answer.
But it's a great reason to come visit you.
Right.
I love it. Awesome. Well, I think we did the questions. I'm just going to do a quick scroll, but I think we did the things.
Yeah.
Yeah, I love it. Awesome, everybody. Thanks for sticking with us on a long one.
Yeah.
Dr. Loya and Jess, I appreciate the heck out of both of you. It's always a pleasure to work together. I'm going to go ahead and hit stop on this recording, and we're going to call it a night.